Good morning to one and all. Presenting the topic of typical and atypical phenotypes of ocular tuberculosis. Ocular tuberculosis represent a form of extrapulmonary TB which can affect various ocular tissues and can present with a wide range of symptoms. The pathogenesis of ocular tuberculosis. The current understanding of TB uveitis pathogenesis relies on the concept that ocular inflammation can be because of a hematogenous dissemination of Mycobacterium tuberculosis, causing a direct infiltration to monocyte and related granuloma formation. The central role of RPE in Mycobacterium tuberculosis and phagocytosis and orchestrating of immune response have been identified. There is also the presence of autoreactive intraocular T cells and an elevated levels of cytokines like interleukin 6, 10, VEGF factors. Intraocular tuberculosis is a great mimicker of various uveitis entities. TB uveitis is a conundrum because of its diverse clinical phenotypes. Now, how does TB present in the eye? There could be a typical phenotype as well as an atypical phenotype. Typical phenotypes, if you see them, you think of TB. Atypical phenotypes are those which becomes a diagnostic challenge. The phenotype doesn't look like TB, but the TB test becomes positive. So the various clinical presentation of ocular tuberculosis, it can be of an intraocular tuberculosis presentation or as well as an extraocular presentation. The intraocular presentations could be of a anterior uveitis, intermediate uveitis, posterior uveitis and a panuveitis, retinitis, retinal vasculitis, neuroretinitis, endophthalmitis and panophthalmitis. Now let's get over them one by one. The typical presentation of anterior uveitis is of a chronic granulomatous anterior uveitis with mutton-fed keratic precipitates and iris nodules, which if present near the pupillary border is called as Koppe nodule, and the stroma it is called as Busacca nodule. There would be also the presence of a broad-based posterior synechiae. Intermediate uveitis usually presents with unilateral or bilateral asymmetry that resembles pars planitis. The features include moderate to mild vitritis, large snowballs, snow banking, peripheral vascular sheathing, cystoid macular edema. So this is a fundus picture showing snowballs in a patient with intermediate uveitis. FFA shows leakage in the typical wheel-spoke pattern suggesting of cystoid macular edema. The second presentation would be of a posterior uveitis, which predominantly involves the choroid inflammation. In tubercular posterior uveitis, the ocular changes can be divided into 4 groups, that is in the form of a choroid tubercles, tuberculoma, subretinal abscesses and a serpiginous like choroiditis. First, choroidal tubercle, that is a multiple small grayish yellow nodules with indistinct borders which may be unilateral or bilateral, predominantly located in the posterior pole. The margins later become sharp and distinct and the center turns yellow to white with a surrounding ring of peripheral pigmentation, and this process eventually results in the formation of an atrophic scar. This is an FFA picture of the choroidal tubercle which shows early hyperfluorescence of the peritubercular tissues with a hypofluorescence of the tubercle which appears as a ring of fire appearance. Late phase, the fundus fluorescent angiography shows a uniform hyperfluorescence. The tuberculoma would be the second presentation, which can be appearing as a single multiple yellowish subretinal lesion with the fuzzy borders surrounded by exudative fluid. Hemorrhages and retinal folds may be seen in the tuberculoma surfaces. This is a right eye fundus photograph showing a tuberculoma. The OCT shows large homogeneous hyporeflective choroidal granuloma with a subretinal fluid, which can be a contact sign. ICGA shows hypofluorescent lesion in the early phase, remaining hypofluorescent in the late phase. So we often get confused with sarcoid tuberculoma and tubercular uveitis, which can be differentiated with OCT as a large elevated lesion in the choroid involving the outer retina. In sarcoid, there will be stromal involvement with multiple. It's not as big as the choroidal tuberculoma seen in the tuberculoma. It's seen as a very minimal outer retinal changes when compared to the TB retinal granuloma. The second feature, the other feature could be of an occlusive retinal vasculitis, which is typically presented as in the form of a retinal periphlebitis, involvement of the vein rather than arteries. There could be perivascular sheathing with exudates and retinal hemorrhages. The presence of perivascular choroidal pigments or small choroiditis patches is highly suggestive of a tubercular etiology. The complication of occlusive retinal vasculitis could be of a macular edema because since it's an occlusive nature, it could have a retinal and optic disc neovascularization resulting in vitreous hemorrhage, tractional retinal detachment, iris neovascularization and neovascular glaucoma. Eales disease is an idiopathic form of occlusive retinal periphlebitis with a high risk of retinal neovascularization and related sequelae in young healthy individuals from TB endemic areas has been strongly correlated to an immune-mediated reaction to Mycobacterium tuberculosis. This is a fundus picture showing leakage from the vessel wall with more intense from the venules and adjoining capillary non-perfusion. The other picture would be of a serpiginous-like choroiditis, which can be multifocal and a diffuse plaque-like choroiditis. Multifocal is initially a discrete, later confluent yellowish lesion, slightly raised edges, showing an active edge, a wave-like progression and a central healing. Which can be non-contagious to the optic disc. It is unilateral or bilateral with mild vitritis. The diffuse plaque-like choroiditis shows a solitary placoid lesion with an amoeboid spirit. So, this is a fundus photograph which demonstrates extensive retinal pigment epithelial changes, atrophy, and bilateral scarring. The FFA shows a hyperfluorescent centrally with a hyperfluorescent borders which do not leak. ICG shows lesions as hypocyanes. How do we differentiate between a serpiginous choroiditis and a serpiginous-like choroiditis? Serpiginous choroiditis is a bilateral condition. Serpiginous-like choroiditis can be a unilateral or a bilateral condition. There is absent vitreous or anterior segment inflammation seen in a serpiginous choroiditis. The other can be associated with an inflammation. The lesions begin juxtapapillary. The lesions are usually beginning in the posterior pole. There is pigment clumping at the borders of the heat lesions and pigment clumping in the center of the heat lesion. This is not a multifocal lesion. This becomes a multifocal. So, how does TB affect the optic nerve? It can be in the form of an optic nerve tubercle, papillitis, papilledema, optic neuritis, retrobulbar neuritis, neuroretinitis, optic chiasmic arachidonitis. There can be the presentation of an endophthalmitis or a panophthalmitis. This is of an acute onset and shows rapid progression with destruction of the intraocular tissues. The inflammation may be intense enough to produce hypopyon. These were the typical manifestation. Moving on to the atypical manifestation. Atypical manifestation can be of a wide variety of uveitis, from a non-granulomatous anterior uveitis to an intermediate uveitis, non-occlusive retinal vasculitis. TB should be excluded in all cases of atypical anterior uveitis not responding to conventional therapy in patients with socio-epidemiological risk factors for TB. Not to forget to mention about the extraocular tubercular manifestation, which can affect the eyelid in case of a localized mass, lacrimal gland as granuloma, conjunctival granuloma, ulceration, hypertrophied papillary lesions, sclera as a focal or a non-necrotizing scleritis, nodular and diffuse scleritis, scleromalacia. Cornea can be in the form of an interstitial or a diffuse keratitis, flictinulosis, and corneal edema. Just to mention few case reports published in various journals. So the first case is of an unusual presentation of a tubercular panuveitis, initially diagnosed as misdiagnosed as sympathetic ophthalmitis, and hence was treated with IV and corticosteroids and immunosuppressive. But due to worsening of the symptoms in chorioretinal lesions, the patient was further investigated and was found to have a positive tuberculin test, and CT showed a positive mediastinal lymph nodes. And on enucleated specimen of the left eye showed the presence of acid-fast bacilli. Hence, the patient was started on ATT and the symptoms got cured. This is another case report which shows immunocompetent women presented with a subacute intraocular inflammation with high intraocular pressure, which was mimicking a phacolytic glaucoma. The further treatment was done, cataract extraction was done, and was put on anti-inflammatory medications. Inflammation did not subside as expected. 7 weeks later, the patient presented with the scleral necrosis or scleral abscesses, which was subsequently explored for microbiological investigation and was found to be having a tubercular etiology, for which anti-TB was treated and the abscess was cured. This is another case report which shows a rare presentation of ciliary body and limbal lesion, which is diagnosed in an immunocompetent young female or male. The individuals with compromised immune status usually presents with atypical presentation. Tuberculoma in the sclera is a rare presentation of tuberculosis and with very few reports. This is another unusual case which was of a tubercular optic neuropathy associated with a choroiditis. So a case of presumed tuberculous optic neuropathy with a concurrent choroiditis which presented following a choroidal involvement in the other eye. This case highlights a contagious spread of the infection from the choroid to the optic nerve and its successful management with the systemic steroid and ATT. Choroidal involvement in a case of inflammatory optic neuropathy should raise the suspicion of a tuberculous etiology. These cases emphasize the need to be aware of the ocular tuberculosis in an endemic area, especially with unusual presentation and prolonged clinical course of the ocular inflammation. So finally, to conclude, when to suspect TB? Typical phenotype, the phenotypes itself makes us think of the tubercular etiology. What about a typical phenotype? We need to suspect when all other possible infections or diseases is ruled out. Disease is recurrent despite the treatment with corticosteroid or immunomodulator therapy. In endemic countries, TB must always be ruled out. Sometimes, when repeated, test becomes positive for TB. Thank you.
Thank you, Dr. Sithara, for a very informative talk on the different phenotypes of ocular tuberculosis.